The next presentation has an intriguing title. It's by Professor Giuseppe Vergaro from Italy, who's written a very nice paper that I remember reading on mortality in different groups of heart failure patients in 2019. But this presentation today is about a subject that I'm very interested in, which is cardiac amyloidosis, that I've been working on very hard for the last 3 years. And it is intriguing because it's sequential transthyretin, TTR, and immunoglobulin light chain cardiac amyloidosis in the same patient. And that is something which sounds amazing. And I'm really looking forward to hear this presentation. Dr. Vergaro, please go ahead. And thank you for being with us.
Well, good evening or good afternoon, everybody. It's a real pleasure and real honor to be with you this evening. Yes, indeed, we are shifting the topic of the presentation from valvular disease to cardiomyopathies, let's say. And yes, cardiac amyloidosis is a field of growing interest basically everywhere in modern cardiology. And we have also approached cardiac amyloidosis since, let's say, 6 or 7 years, and we have studied this disease a lot. And this is a very nice case, in my opinion, really explicative, and we have published it in Jacques' report as well, together with my team in Pisa. Just trying to go on with my presentation. Sorry. Okay, so and this man first came to our attention in 2016. It was 80 at the time, and he had a history of hypertension, and he also had, like a lot of patients at that age, he had been diagnosed with a monoclonal gammopathy of uncertain significance, which was typed as EGMK. And he first came complaining dyspnea, which was at that time near class 2. His blood pressure was 130/80 and heart rate was 76 beats per minute, and physical examination was basically unremarkable. You can see his EKG showing some mild abnormalities in ventricular repolarization in lateral leads. And these are frames from his echo, who was showing an increase in septal and posterior wall thickness with a preserved left ventricular ejection fraction and a grade 1 diastolic dysfunction. This is the movie of the echo, and also the mitral regurgitation, which was mild, basically, is shown. Going on to the lab biohumoral examination, well, a moderate increase in NT-proBNP was observed, which was 460 at the time, and also high-sensitive troponin T was mildly elevated, which was as up as 24 nanograms per liter, in the presence of a preserved renal function, as shown by the creatinine levels, which were basically normal, was less than 1. Coherently with his previous diagnosis, a monoclonal EGMK protein was detected at that time with a basically preserved K to lambda ratio. And also the urinary immunofixation showed a kappa-Bence-Jones proteinuria. We went ahead in terms of phenotypic characterization of this patient by performing cardiac magnetic resonance in order to identify which was the cause of this left ventricular hypertrophy. And also the cardiac magnetic resonance confirmed the presence of an increased left ventricular mass index with maximal septal width of 23 millimeters. Also, a mid-wall late gadolinium enhancement was detected at the anterior septum, as well as subendocardial LG at the inferolateral and the inferior left ventricular wall. So in the suspicion, indeed, of the presence of transthyretin amyloidosis, the patient was submitted to, of course, a diphosphonate scintigraphy, showing a very mild uptake in the cardiac region. I've also shown the 3D reconstruction of this examination because, indeed, it was pretty mild. It was classified as a Perugini score 1. And it was mainly localized at the septal and the inferior wall, as shown in the panel on your right. So we decided to go on and to further explore a possible diagnosis of this patient to confirm our suspicion of transthyretin amyloidosis by performing endomyocardial biopsy. Of course, we first performed coronary angiography, who could not show any hemodynamically significant lesion, and also the periumbilical fat biopsy, which was negative, as frequently happens in TTR amyloidosis. On the other hand, endomyocardial biopsy showed was positive at conglomerate conglomerate staining, and the immunohistochemistry demonstrated a positive staining for transthyretin, while kappa and lambda staining was negative. The patient was further studied on genetic background, which could not show any mutation in the TTR gene. So our diagnostic conclusions were basically the ones confirming an early stage ATTR wild-type cardiomyopathy. And the patient was initiated with therapy basically for heart failure with bisoprolol, valsartan, and spironolactone. As you can see here, this is a picture taken from the latest recommendation published only a few weeks ago concerning the diagnosis and management of patients with cardiac amyloidosis. Our choice was indeed coherent with the current indication. Indeed, our patient had a grade 1 scintigraphy, but most importantly, he had positive hematological test. What we can learn from these kind of approaches that whenever we have any suspicion of cardiac amyloidosis, these are those tests that needs to be performed. So on one side, diphosphonate or bone tracer scintigraphy. On the other side, the study of the hematological tests. And since we had a mildly positive scintigraphy and also positive hematological tests, the patient needed, as it has done, an histological confirmation and the typization of the amyloid. The patient was then followed up at our clinic during the following years, and he maintained clinically stable. In the meanwhile, he also was performing his routine evaluation at the hematology department, where he was diagnosed in 2018 with Waldenström macroglobulinemia. And he also repeated an HDP scintigraphy in April 2018, showing an increase in cardiac uptake, which was now scoring 2 at the Perugini score. Things changed more or less 3 years after his first admission at our department in January 2019, when the patient started complaining worsening dyspnea, which was at that time in NIA class 3, and also presented at our attention with mild bilateral ankle edema. At that time, cardiac biomarkers had increased, and NT-proBNP reached more than 2,500 nanograms per milliliter, and also eye-sensitive troponin T had increased up to 48 nanograms per liter. The K to lambda ratio also increased to 4.2. As you remember, it was preserved at the first evaluation. The patient was therefore referred for baseline echocardiography, showing an impairment in left ventricular ejection fraction, with also mild pericardial and bilateral pleural effusion. These are the images from his echocardiography. You can see also that the entity of the severity of mitral regurgitation had worsened at time of our second assessment. And this is a panel showing how all the diagnostic examination have changed during these 3.5 years follow-up. As you can see, most notably, the diastolic function has worsened since 2016 to 2019, and also the extent of left ventricular hypertrophy and the extension of late gadolinium enhancement at cardiac magnetic resonance examination have significantly worsened during these 3 years, as did also the HMTP scintilla, shown by the panels on the right. What is of interest indeed is that in this case, the patient has been diagnosed with Waldenstrom macroglobulinemia, which is not indeed one of the most frequent plasma cell dyscrasia that we currently see in patients, especially in older patients, like, for example, the MGUS smoldering myeloma or also the multiple myeloma. But these came to our attention, and we decided to go on with other examinations in this patient. Of course, the chorangiography was performed again and did not show any significant difference compared to the previous angiography performed in 2016. And we decided to further explore this case by performing again, a second time, a myocardial biopsy. And we were not surprised indeed, given the clinical presentation of the patient, to discover that further to the transthyretin amyloidosis that the patient was already documented in this patient in 2016, and which had indeed extended, as demonstrated here by the immunohistochemistry, which was already positive for TTR in 2016, but was much more positive now in 2019. We also observed positivity for kappa light chain. So we concluded that the patient had suffered at that time of dual cardiac amyloidosis of both type, ATTR wild type and AL. The patient was thus initiated with hematological therapy with oral chlorambucil and prednisone. He had no treatment-related complication, and was referred for a routine follow-up at our outpatient clinic. Last contact was on November 19, and was asymptomatic with no sign of congestion. Left ventricular ejection fraction had improved to 56%, and he has also shown a partial hematological response to chemotherapy, as demonstrated by a decrease in kappa to lambda ratio. So what are the main messages I want to conceive to you with this presentation? Well, the first of all is that cardiac amyloidosis is not that infrequent, and it may account for a significant number of cases of heart failure, especially in the elderly population. Another important point is that we need to perform a timely diagnosis of cardiac amyloidosis, especially for those patients in whom AL amyloidosis is suspected, because the early initiation of hematological treatment can save life. Another important point is that on one side, ATTR amyloidosis can coexist with other disease. It is a disease of the elderly people. So if you have a patient with, for example, another cardiomyopathy or with coronary disease, well, ATTR can coexist with all these diseases. But also ATTR and AL amyloidosis can be present in the same patients and can develop in different time during the lifetime of a single individual. So there are different, indeed, red flags that we need to consider when to raise the suspicion of cardiac amyloidosis in different patients, and all these red flags can come from different fields, from the clinical presentation, from the EKG, from the imaging, and also from biomarkers. These need to be particularly taken into account, because they can provide us with very early signs of clinical worsening and eventually the appearance of another alternative type of amyloidosis. And this is indeed reflected by what we have stated in a recent paper published in the European Journal of Heart Failure, demonstrating that also mild elevation of cardiac biomarkers can be indicative of early stages cardiac amyloidosis, and those elevated levels of high sensitivity troponin or anti-proBNP or the BNP, which we are used to observe in patients with amyloidosis, usually reflects a disease which has been diagnosed pretty late in its clinical course. So thank you for your attention.
Oh, thank you very much. This was an amazing case. I mean, and we've seen the comments coming from all the panel. I must have missed something. Can I just ask you a question, which is probably a very stupid question, so don't be angry.
For sure.
Yeah. If I just say, why is this not just AL amyloidosis? Why is it combined TTR? I mean, the SPECT is negative. Congo red will still stain any amyloid, even subcutaneous fat in an AL amyloidose or a biopsy from the colon will stain with Congo red. I mean, Congo red is not specific for ATTR, right? It's for all amyloidoses. So why is this not just simple AL amyloidosis because of the macroglobulinemia? Why are you saying that this is also TTR? I'm sorry. I'm a beginner in amyloidosis, and I hope you're not upset by this question. But, I would have just diagnosed AL amyloidosis and sent him to a hematologist. I don't see the proof of the TTR.
Well, indeed, we have two different proofs of the presence of ATTR amyloidosis. One, which is indirect, coming from bone tracer scintigraphy, which was only mildly positive at the very beginning and then worsened during the follow-up. And the second proof is that the amyloid tissue within the heart was underwent a typization with immunostaining, and that immunostaining revealed the presence of TTR within the amyloid, together with light chains. So that's why we have diagnosed a combined amyloidosis.
Okay, thank you.
Hope it was enough.
Yes, just another quick follow-up question.
Yeah.
This is a case report. You mentioned at the bottom of one of the last slides that they can exist in the same patient. Are you aware how many cases were reported with both types of amyloidosis in the same patient?
Well, in our center, we have 7 patients with both AL and ATTR amyloidosis, but this was very special as a case because we had the chance to see the development of the disease at 2 different time points. So this patient did not suffer of AL amyloidosis at first examination, while he had the time to develop another disease during his follow-up. But if you see the patient at an exact time point, well, you can see both AL and TTR amyloidosis, especially in elderly patients.
Okay, can I ask?
Okay. Yes, I think Dr. Graspa would like to comment as well first.
Can we ask you to? It's a wonderful case. I mean, fascinating. I was mind-blowing, beyond my understanding, to be honest. So this I would like to comment. I don't have any special comments. Only I would like to say my apologies because I won't be able to see the last case because we have a meeting with Dr. Fuster in 10 minutes. So to all of you that you are watching, my sincere apologies that I will leave slightly earlier.
Thank you, Julia, for joining us tonight. I know that you have a meeting now with Professor Fuster. Thank you again. Before we will conclude the session after Professor Shawi, thank you again for your support by Jack Case Reports. And I think we still, despite we are in the 5th wave, but we still have a long way for merge meeting together. And I think we will talk later about our future plans for the coming waves. Thank you, Julia, and have a nice meeting with Professor.
Thank you so much. Thank you all. And as I texted you that few cases they're so amazing that please submit also to the journal. So Thank you so much, all of you.
Thank you, Julia.
Thank
Thank you very much.
Professor Hani, continue.
Yes. I think there was a question. I interrupted the question. Did I?
Professor Tariq.
Yeah.
I have two questions. Thank you for this excellent case presentation. Do we, for diagnostic algorithm for patients with amyloidosis, do we need to do for all patients technetium scintigraphy and light chain? The first one. The second question about the anticoagulation, the role of anticoagulation. Cardiac amyloidosis patients are at risk for intracardiac thrombosis. Is the role of oral anticoagulant in patients with sinus rhythm?
So thank you very much for your question. Well, concerning the therapeutic option, we do have therapies which are hematological therapies for AL amyloidosis. The availability of drugs addressing TTR amyloidosis are heterogeneous across all over the world, depending on the status of the local regulations and the approval of the use of some of the drugs which are coming to the use in this context. Well, yes, whenever you have the suspicion of cardiac amyloidosis, there are two tests which are mandatory. The first one is bone tracer scintigraphy. The other one is the study of the hematological pattern. As concerns the last question, what is the rule of anticoagulation? So I will start with what is the rule. So the rule is to use the same criteria in patients with cardiac amyloidosis as in all other patients. So this is the rule, because we don't have any other recommendation, or there is no robust evidence supporting any other behavior. But what I think, but this is a personal opinion, is that we should keep the threshold for anticoagulation lower in patients with cardiac amyloidosis, because we have described several cases of patients with peripheral embolism and also with stroke in patients with sinus rhythm and cardiac amyloidosis, because you have, especially in patients with AL amyloidosis who also have abnormalities in coagulation, you have an atrial standstill, which has been documented by advanced echocardiography and also by cardiac magnetic resonance, which may lead to the development of intracardiac thrombi in these patients. So what we think is that as soon as you have something, and the minimal reason to use anticoagulation, you should use in these patients.
Yes, thank you very much. That was a great question, Professor Tare, and I agree. This atrial myopathy with lack of atrial contraction, is something which has been noticed in cases of amyloidosis. I have one last question. You mentioned at the beginning of the workup that you started the patient on several treatments, including valsartan. Right? Am I right?
Yeah.
And those patients don't do very well on conventional heart failure treatment. Actually, some of them get worse, as you know well. So how did the patient respond, and what was your rationale for giving standard heart failure treatment to this patient?
So there is indeed a lot of concern about the use of neurohormonal antagonists in patients with cardiac amyloidosis. What we do is to use them cautiously, because there are at least a couple of reasons. The first one is that we have demonstrated the presence of neurohormonal activation in patients with cardiac amyloidosis who have elevation of aldosterone, renin activity, and also epinephrine and norepinephrine. So that is the rationale. The second point is that these patients may benefit, for example, from beta blockers in terms of reduction of heart rate, which is, this is in my opinion, less than compensatory. the point is that these patients usually do not or scarcely tolerate neurohormonal antagonists if these drugs are used as in all other patients. So you should be even more cautious when initiating and titrating this drug. The titration should be much slower than in other patients. And using this kind of tricks, you may introduce and keep these patients with this treatment that potentially may be useful in these patients.
Thank you very much. That was really wonderful. Any more questions from the audience or the faculty? I'm looking at the chat. There's no more questions. So thank you very much again.